I'm a nurse. I teach in the nursing department downstairs. I've been a nurse for about 30 years, and I don't work at the bedside anymore because I have too many structural problems, including a hip that's going to get replaced in about a month. So I'm going to talk to you as a follow-up today to some of the anatomy that we talked about last time as far as the gut and digestive system goes. And we're not going to go take a deep dive into any one of these things. And I had to make a choice as to what to present, because there are so many conditions, so many ailments of the digestive system. It's, you could make a separate PowerPoint about each one. But the point is, I'm talking to just a few of these today, and we're going to go a little deeper. Okay, so let's head out. Oh, a little review. Hopefully you can see this okay on Zoom, and I don't get my fat head in the way here. But everything starts the moment you put an item or a spoonful or a forkful of food into your mouth, because the digestive juices in the saliva begin breaking down your food from that point on, and it moves down the esophagus, past the pharynx, and by waves of peristalsis. And the stomach, believe it or not, has very big waves of peristalsis that both churn and move the food from the biggest parts of the stomach all the way down to the passageway where the pyloric sphincter is, where then that opens up and moves food down into the small intestines. And then what comes into play from there, of course, you have your accessory organs like your pancreas, liver, and gallbladder. They make their biggest contribution. And again, if you remember, 90% of your digestion takes place in the small intestine. Okay. And so as food is moving, slowly but surely through the small intestine, a lot of work is done on your food, and a lot of absorption is done in there at the same time. And then it moves to the large intestine at the ileocecal valve, which opens up and moves the food into the beginning of the large intestine. And then the food at that point gets formed into stool, little by little. Where what happens here at that part of the gut is you get a lot of water reabsorption, and by doing that, stool is formed.
Excuse me, Rob, but I can't figure out where the small and large intestine are. What color are they on your chart?
Good golly. Okay, yes. All right, food starts here in the mouth and then moves into this direction. Sorry about that. Thank you for pointing that out to me, that I should be using my pointer to actually show you where I'm going. Down the esophagus, okay, and whoops, a daisy, sorry. And then here into the stomach. Now, food gets pushed by waves of peristalsis into the small intestine. Now, the small intestine is, again, 22 feet long when you stretch it out, longest part of our digestive system. So this is the small intestine where the majority of absorption and enzymatic impact works. Now, here is the large intestine. Okay. Now this is about 5 feet long. And once again, this is review. There is an ascending part, transverse part, a descending part, and then it leads into the area of the sigmoid, which is the final area of the colon, because large intestine is known as the colon. And then finally, when this area of the intestine gets enough pressure built into it, you're ready to have a bowel movement. And that's where the rectum and the anus come into play. So that's just a brief review. Okay.
Well,
Yes, go for it.
I mean, I don't want to, just a quick question in that diagram where I don't know if I pronounce it right. The close to, the bag, when you can't go to the bathroom regularly, they give you that cluster,
Oh, colostomy.
but yeah, whereabouts would that be at in that diagram?
Typically right around this area. And again, that's because of disease usually. Can be cancer, can be Crohn's disease, which is an inflammatory bowel disease. It can be due to, diverticulitis that's beyond treatable. Most of that region of the large intestine becomes diseased to a point where next thing is perforation, and you don't want that. So
Okay.
that takes place right around here. Now, yeah, oh boy, that's a whole nother lecture talking about
Oh,
ostomy.
no, I just want to know where it would be at. I don't even know all that.
Okay, all
Okay.
right, no
If you-
worries.
Sorry.
But typically in this area here, and it's interesting you ask about that because it used to be common practice to reconnect that part of the bowel after a certain amount of time. And they've already removed the disease portion. And so they used to bring part A right here and part B out to the surface of the abdomen. So it was called a double barrel colostomy. They don't do those much anymore. What the doc usually does is he'll tie up the distal end. And interestingly enough, they'll bring the end that's closer, proximal end, out to the stomach for a while. And what usually freaks people out is that they continue to have what appears to be a loose bowel movement, but it isn't. And what I've often had to tell patients is that your intestine continually secretes mucus. And so that is what's being expressed at the tail end.
Yeah, because it has to protect the lining.
Okay, thank you.
Yeah,
It still thinks there's stuff coming, so it's.
yeah, it's doing what it's supposed to do, doing what it's designed to do. So you still have to look after this and after this, if that is the case, So it just depends on what's diseased and what's removed. Okay, so let's move on. Next slide, digestion and absorption. Okay. More review here, just quickly. GI system, basically known for its role in digestion. There is the mechanical influences that break up food into smaller and smaller and smaller parts, consistency. And then there's the chemical, which is things like your acids, the different enzymes secreted into the digestive system that kind of take over from there and break the food down into a consistency where nutrients, vitamins, fats, proteins, etc., can be absorbed. So again, other influences on the GI tract too, they could come from, whether your pancreas, which is it is an accessory organ and does secrete. I want to say it's an endocrine and an exocrine gland because there are certain enzymes it secretes directly into the digestive system and others that go right into the bloodstream. Insulin is what I'm talking about. And same with the liver, only the liver, we're talking about bile stored into the gallbladder, which unfortunately becomes an issue for some people. And stones are created there and cause all kinds of problems. But I'm not going to talk about gallstones today. The other impacts come from your brain, so your nervous system brain by way of the nervous system, your circulatory system, the hormones and enzymes I just talked about, they play a big part in digestion and absorption, and the transport. Once these nutrients, vitamins, etc., have been absorbed, well, how's it going to get to where it's going to go? It's going to go to where it needs to go by way of the bloodstream, capillary beds to from there larger vessels, and it can move to the places where it needs to go. So in the end, though, everything we eat or drink, for that matter, is acted upon by the digestive system and or the kidneys. But the kidneys, I'll save for another talk. All right. So again, this is more background. You with me out there? Okay, well, hopefully you are. Again, feel free to just shout out if there's like a question, or hey, you didn't talk about this, and it's written right here on the screen. So just let me know. Let me know if I go too fast. So what could possibly go wrong? Oh, I did a search on the internet. This is one of the better parts of the internet I like. There's some other parts I don't like, but looking for very common ailments. And depending on the source, there were the top 10, others there were the top 15. And all these lists, I found four different ailments that were common to most of the lists. And that would be gastroesophageal reflux disease, otherwise known as GERD, or IBS, irritable bowel syndrome, not to be mistaken for inflammatory bowel syndrome or disease. This is different. Gastroenteritis, that's another one that's very common, lands you in the emergency department a lot of times for rehydration and antiemetics, and then antibiotics in some cases.
Antiemetics.
Things that keep you from being nauseated and vomiting, because gastroenteritis can cause that, either by a parasite, bug, or some other some other pathogen. And then, of course, diverticulosis, very common. And that happens down in the happens in the large intestine. And that's really about little out pouches. And I say out pouches because the pouching doesn't go in, the pouching actually goes outward. And so it looks like a little tiny grape that pouches out. But the problem with that too, without getting into this before we move into these other things, is that, well, anything and everything can collect in those tiny pouches. So GERD. All right. I don't know how many of you out there deal with GERD. I do, and it's no fun. I've tried many things. Prilosec helps, and that's a proton pump inhibitor, by the way. Other drugs like Pepsid, which is an H2 receptor blocker, or Rolaids, which is another fast-acting chewable that works on, basically works more temporarily on an acute case of GI reflux, better known as heartburn. So that's why I put AKA heartburn, because sometimes it feels like chest pain. This is kind of like, well, you may be having a heart attack, or at least the fear is there.
Definitely, if you've had a heart attack.
Yeah, if you've had a previous, that's no joke, that's for sure. So this is a regurgitation of stomach contents. Can be big, can be small, from the stomach. Sometimes it's even backed up from the duodenum, which is the first part of the small intestine. So we're talking about a highly acidic contents, and an acidic contents that's usually around 4 pH, which is pretty acidic and burns. Because when you think about it, the stomach has special lining and secretes special mucus, actually, that tends to keep the worst parts of that acidic contents from burning away at your stomach. So again, when people have this too, and they have episodes, they may actually have a small amount of vomitus. That is, so it's not just a burning here, or it's like they can actually taste the stomach contents coming up, like they're about ready to vomit. And part of the reason is you have a sphincter here. Once the food makes its way down the esophagus, there's a sphincter that opens and closes. Supposed to close and stay tight once the contents make their way down into the stomach. But what happens is sometimes that sphincter becomes loosened or becomes incompetent in some way. And depending on what angle you're at, what you're doing, how much you've just had to eat or drink, will favor the contents coming back up. And that kind of leads me to one of the things with individuals who have this is they ought to eat smaller meals and not eat so much at one time. But I'm getting ahead of myself. So they're caustic. So that's why you have the feeling of heartburn, a burning sensation. I want to say almost, tasting your own vomit. So yeah, that's pretty graphic. So this picture actually does a pretty good job of illustrating when you have a competent sphincter here, gastric contents stay in here as they churn, and acid has a chance to work on them. And there are other enzymes that begin working at this point. And if everything works out well, peristaltic waves will start moving things down, and the pyloric sphincter, or it's the lower intestinal sphincters, another name for it. And that's usually, oh, I lost my cursor, what happened? That usually happens here, where this will open up and contents move in the right direction. So this is a pretty good picture of it. Healthy on one side, not so healthy on the other, GERD. All right, any questions so far?
I once got off at a subway station and it was all private sector. Both sides of the station, every, I'm like, what the heck? And I went up and it was the heart of the financial system.
That makes sense. Yeah, people under a lot of stress and pressure, this can become an issue.
We couldn't understand that.
Okay, the question is regarding an area that Kevin visited where there are a lot of Prilosec ads. Exclusively, pardon me. And so, no subliminal messaging there. And this was an area where primarily this was a business district, financial district. Was that Sacramento, Kevin?
No.
It was somewhere else. Okay. New York City. Oh, enough said. So that makes perfect sense. It's high pressure, stress, tension, which basically doesn't help your heartburn or may contribute to it, actually. So that's what we just mentioned. Sorry about that. Thank you for reminding me that I need to actually state the question and who actually brought the question up. All right. So where does this come from? Why? How? Usually this kind of just comes on. You start feeling chest pain, and you can it can be mistaken for angina, which is that chest pain, chest pressure. And this is where you have to really be careful. If this is something that persists and doesn't go away if you pop a Tums or a Rolaids, but persists, you don't want to wait that long. you want to take care of this by calling 911 to make sure this isn't in fact a heart attack. Because there's similar, I want to say similar signs and symptoms. I want to say too, that when you have a lot of acid coming up from the stomach or small intestine and making its way up into the esophagus, there might be a little bleeding because of the erosive contents that's coming up. So it's not uncommon for individuals with really bad heartburn, really bad GI reflux to actually spit up a little bit of blood. Okay. So now GERD. This can be a situation where an individual has maybe they overeat and they do it on a constant basis all the time. They overeat. Well, again, that's where I mentioned that person may want to eat meals in smaller doses, smaller portions. Okay. Now, women oftentimes will experience GERD because during pregnancy, everything gets pushed one way or the other, up and around. And I want to say it favors that possibility of having heartburn. Just does, till the baby's born, etc. Now, weight gain. That's been known to be a culprit behind a lot of GI reflux. And weight gain around the thorax, the abdomen especially. It's additional girth, additional pressure on, I want to say, the internal viscera, our guts, for lack of a better way of putting it. So there's, again, I mentioned earlier, there's an abnormal relaxation of the cardiac sphincter. Okay, and that may actually have a nervous system component to it. And it might be actual muscle, a muscular, I want to say a neuromuscular component to it, why that develops. And I want to say too, if you have a lot of pressure, intra-abdominal pressure especially, that pressure will eventually put a lot more, exert its pressure actually onto that sphincter and continually make it open up a little bit more and a little bit more and a little bit more. And intra-abdominal pressure is, I want to say, it's a culprit for a lot of things because it plays a part in one of these other illnesses I talk about. So that may be partially behind why GERD occurs. Patients with a hiatal hernia, which is not as uncommon as you might think, and that's where part of the stomach pushes up through the opening in the diaphragm. Because when you think about it, you have a lot of things, the esophagus, it has to pass through the diaphragm to get to the stomach. Well, if pressure behind the scenes causes the stomach, well, part of the stomach to push up, that will exert enough pressure to, I want to say, not pressure, but it could cause you to have stomach contents just naturally be pressed up, pushed up, forced up. That's what I'm looking for. Sorry, I have to look for words sometimes. It causes the contents to be forced up, and then you're going to experience reflux on a lot more regular basis. But there are surgeries to have that hiatal hernia fixed and have the stomach put down where it should be. But unfortunately, that is also, it also plays a big part in this. So does that make sense as part of why this is happening? Just let me know if something is like unclear. All right, medicines and food. You know, you've seen these commercials for either Pepcid or Prilosec. Now I can eat all the spicy food I want, or I can eat all the greasy food I want, or I can eat all the, peppers, anything hot and on fire now I can eat, because guess what? I take Prilosec OTC. I'm sure all of you have been exposed to all of these commercials. So, but there are some common medications. Some of them are heart medications, like calcium channel blockers, which is, it opens up blood vessels, relaxes those to lower blood pressure. It also works on arrhythmias to, I want to say, doesn't cure the arrhythmia, but it does, in fact, it does treat it to a point where you're not experiencing arrhythmias quite as often. All right. So some of these drugs can actually contribute to or exacerbate what's already existing, like GERD, for instance. There are osteoporosis drugs like alendronate 2 that can, I don't want to say lead, but can exacerbate GERD. Theophylline, which is a bronchodilator. We used to give a lot of theophylline when I first started nursing. We don't see much of that anymore. Sometimes we'll get a theophylline drip, but we used to give it a lot orally. That also is a drug suspected of contributing, if not being a cause of your heartburn. Demerol, which is also an opioid, is not used very often anymore because of some of its, some of its side effects. That would also be a contributor to heartburn and acid reflux. Now, this is something that gives me a lot of problems. I drink a lot of coffee. And I've been drinking coffee for the last 45 years. And, unless something really dire happens, I don't intend to stop. I sometimes will drink decaf, but it's an irritant. And so is alcohol, for that matter. And so both of those are associated with acid reflux. Both tie in. Any drug in the end that relaxes that esophageal sphincter will aggravate and will worsen your acid reflux. Let's see. This is the drug part. Oh, shoot. Well, I do not know why food didn't get on here, but it did in the way of coffee and alcohol, and those aren't really foods. But, certain, I know. No, yeah, coffee and cigarettes, they don't represent anything in the food group at all. Yeah, breakfast of champions. But, for some people, it's spicy food. For some people, it's very greasy food. And for other people, it's, maybe a combination of both. Or I want to say it's like, I know some people who can eat the hottest chili peppers whole and not have a problem. But I look at that and I take a whiff of it, it makes my eyes water, and I tell them no. I said, I know what that's going to do immediately to here, and then what finally ends up out there. So, some people it's foods, and sometimes you just have to experiment with different foods to see what aggravates your heartburn. You just have to. I mean, for me, it was like when I was diagnosed with celiac disease, and I realized now I had to avoid wheat products, anything with gluten. And, and then I had to do an elimination diet, which I absolutely hated. But you have to do that with something like this. Simply because if acid gets up here on a regular basis, and that can happen too, by the way, if you're sleeping, that sphincter relaxes, guess what's going to happen? You can wake up, and that's happened to me, with the worst possible heartburn you've ever experienced. And if that's common, it leads to erosive conditions. I think one of them is Barrett's esophagus, and I don't want to talk about that. That's a separate issue. That takes a PowerPoint on its own. But, you know, so I've had to change the angle of the bed. I've had to extra pillows to keep myself at like at least a 30-degree angle. So that does not happen. So you have to make adjustments. Those were suggested by my gastroenterologist, by the way. So he said, you just got to change the angle of how you sleep. Simple, pure and simple. All right, so moving on. Treatments and prevention. Usually what happens is like, okay, in order to see what's going on down here, they have to do esophagogastroduodenoscopy, long word for basically putting a camera and a scope that's fed down your throat, past your esophagus, stomach, and into your small intestine to see what the heck's going on. You know, the doc can look all around with that camera. And of course, you're oblivious because you're out cold most of the time when that happens. So that is a good way for the doc to confirm that you truly have GERD and maybe what stage of GERD you have. A barium swallow is another one. That's god-awful substance. I don't know if any of you ever had to have a barium swallow. Oh, so it's nasty stuff. I don't care what flavoring they put in it. They put strawberry, banana, chocolate. I think, I'm sorry, any way you color this or flavor it, nasty. So that's another way that they can detect gross changes within the stomach and any strictures. Now, of course, monitoring pH is another way, and that can be done by certain invasive procedures, which you probably don't want to think about, and that's to maybe have a tube put down there, grab contents, bring it back up, and then measure it for pH and see what's going on there. Now, treatments, I alluded to some of this. Head of bed has to have an angular change. Now, usually, again, this is whenever you're napping or sleeping at night. Meals have to change. Light meals at dinner, maybe smaller and more frequent meals during the day, okay? And then no eating at least 4 hours prior to bedtime. Lessens the chance of this being a problem for you at night. Other treatments include antacids. I must own stock in Rolaids because I have several rolls all over the place. I have a couple of them in my car, one by the nightstand. They're everywhere. And of course, I take Prilosec. I used to take Pepsid. I no longer take that. But there's a thing about taking these acid reducers that you have to be aware of, because they have a tendency to block B vitamin absorption in the gut. So there may be a process of timing when and how you take these acid reducers and when you take a vitamin supplement, if that's the case, so that it's not going to get in the way of absorption of these very vital vitamins into your system, okay? Now, what's the prognosis? Well, gosh, there's all sorts of ways if you're using common sense to treat this and manage this, okay? Worst case scenario, of complications, there might be surgical procedures involved, to treat an erosive condition in the esophagus. Again, I mentioned the hiatal hernia. That has to be surgically treated if it's bad enough. Of course, if something happens here in the gut and you start forming, heaven forbid, ulcers, that's something that may need to be either surgically treated or procedurally treated. And those are like, when other things don't work, or I want to say, usually this happens when the person is not following a certain regimen they need to start following. Those are the consequences. So how I would teach about this, signs and symptoms awareness. Be aware of, oh, okay, this is definitely a sign of heartburn that I'm dealing with here. Trouble swallowing. Now that happens as kind of an end stage thing. If you have trouble swallowing, that means your heartburn and reflux is in later stages. Is not a good sign, because breathing also can be a problem. And I want to say it's usually a late symptom, which means you might be swallowing contents into your lungs, unbeknownst to you. And they may be little bits by little bits, instead of like swallowing, unfortunately, a whole spoonful into your lungs, which would lead to aspiration pneumonia. I'm talking about little bits of gastric contents making its way into the trachea and down into your lungs. That's a big deal. Now, all right, let's move on to a nicer subject. Irritable bowel syndrome, IBS. IBS. Now, this is a set of signs and symptoms that, might be different person to person, but usually there's bloating, cramping, diarrhea, or just the opposite, constipation. Just depends. A lot of gas, unfortunately, nausea, maybe. Changes in bowel habits usually are associated with the onset of IBS. Now, this is long-term. There's no cure. There's different ways of managing it. Doesn't lead to cancer. Usually does not lead to more serious forms of bowel problems either. Now, there may be some root causes, stress. I want to say with the stress comes intestinal spasm, because you're going to feel this in your gut. What's happening on the outside, what you feel will have an effect down here. I mean, literally in the gut, intestines, stress, it's a big deal. Stress is I could spend all day talking about it for other reasons, but nervous system abnormalities as far as communication back and forth with the gut and the brain. Unfortunately, gut, brain, and intestines, really. Gut microbiome changes. And this kind of ties into what Deb talked about last week. A person's diet, simply your diet may have a big impact on IBS. Some medications, foods may exacerbate, this existing condition that you have. Unfortunately, I have both celiac and IBS. So I get the best of both worlds, You can look at it that way. I chuckle about it until I have a spasm, or I am all of a sudden being overtaken by a big gas bubble, or, oh, I better get to the restroom fast. That kind of thing. So it's fun to joke about until you have, an emergency on your hands. So I have a little chart here with signs, symptoms, some of the treatments, what to avoid typically. A little bit hard to see. I wish I had a larger picture here, but usually this is associated with the stomach and the small intestine. This is where a lot of that happens. Or actually, no, pardon me. I mean, the stomach and the large intestine. That's usually where a lot of this gut problem is happening. So to be taken seriously, but thank God it's something easily treatable. Again, triggers can be certain foods, beverages. It's like my doc said, hey, you got to avoid coffee, man. This is a trigger for your IBS. I said, well, easy for you to say, Doc. Yeah, okay, I get it. I understand, physician, heal thyself. So, he also said, take seriously your sensitivities to dairy products, certain citrus fruits, especially anything acidic. Certain legumes, you mentioned beans, peas, beans, cabbages. I love cabbage, but God, it gives me problems. They're known to trigger episodes. Risk factors. Well, stress and anxiety, big triggers, big triggers. It's part of that emotional part of your brain and response to stress. I want to say it's sympathetic and parasympathetic control when we're talking about, the nervous system. A family history of IBS is certainly might predispose you. Unfortunately, women have a lot more problem with this when it comes to like what percentage, more women than men. Being younger, say under the age of 40, is also one of those things that might preclude you. I don't know. Some as young as 20 recall having these problems at 20, but apparently, according to the statistics, being younger is where this usually begins. Complications. Everything has a complication. Poor absorption of nutrients. And I think that ties into what's in your gut in the way of microbiome and how food is processed. Now, you may have some inflammation that occurs and maybe a little bit of bleeding in the lower intestines. Now, that is only trouble if it's something new, of course, but you want to take it seriously. If you're depressed, if you have anxiety, if you work in a high stress job, this will complicate the matter a lot. Especially when I was working as a nurse on the units, can't tell you how much I relied on Mylanta. And at that time, we used to have 3 bottles of Mylanta in the refrigerator that was for patient use and unfortunately for nurse use. Didn't say that, but we oftentimes. So, yeah, because nursing is high stress, and that really was an exacerbation for my gut. So when to call a doc? Well, when you start noticing bleeding, weight loss, maybe some anemic, and I want to say maybe not necessarily iron, but it might be vitamin deficiency anemia that's a problem. And other maybe unexplained digestive symptoms. That's when you get a hold of your doc and maybe go over symptoms and let's order this, let's order that. So that's when you want to start. Hopefully it doesn't get that bad, but that's when you need to start taking it very seriously. Now, yeah, you notice I just kind of moved from one topic to another without much of a transition. I kind of did that on purpose so there wouldn't be much in the way of, time. But apparently, I'm trying to explain some of this to you in a way that maybe you understand a little better. Now, gastroenteritis, that has a lot of, there are a lot of things that go into it. I don't know if any of you have gone into the emergency department or showed up to your doctor with, gosh, I've felt this way. I have a fever, I'm achy all over. I've had, a lot of trouble with my stomach, shooting out one way, coming out the other, nauseated so much of the time. Usually that kind of thing ends up in the emergency department instead of the physician, your primary physician. It usually becomes such a problem that you go in there and then they do further studies. They look further into the problem as to why, you're running a fever and you're throwing everything up, et cetera. Now, pathogens, and I do mean things like bacteria, viruses sometimes, parasites. Now they'll change what's going on in your gut, and they will frankly cause so much irritation that you will start vomiting and become nauseous as a result too. You'll become feverish because it's some of these parasites or pathogens, are permeable into the blood system and cause other signs and symptoms all over the body. So symptoms, of course, would include diarrhea, vomiting, stomach ache for sure. That's one of the first signs, in fact. Weakness, fatigue. That's malaise. Of course, nausea and fever. So it's not uncommon for people to show up in the ED with gastroenteritis as being their diagnosis. And so, when you think about it, if you're losing fluid by vomiting or severe diarrhea, you're changing, you're becoming dehydrated, and that's a problem. Plus, it's throwing your electrolyte balance off. That's another big problem. So the maldigestion is one thing, malabsorption, maldigestion. So that'll trigger a whole lot of different things in the gut. Spasming, maybe shutting down of the gut. I want to say other things. What else comes to mind? Blockages, possibly. I want to say that it can lead to slowing down of the gut in some cases. There's dehydration for sure. That's one of the biggest problems. Metabolic acidosis, and that occurs because you're losing so much. You're losing so much in the way of electrolytes that, acid too. All the contents comes out one way or the other. It's going to change your renal function quite a bit. You could have acute kidney injury as a result, and acute dehydration on top of your gastroenteritis. So there's ramifications there, big ones. Treatment is usually, let's hook up an IV to you, give you fluids, electrolytes too, antidiarrheals, glycopyramide, or something maybe in that drug class. Antiemetics, which will calm down the nausea and vomiting. But a lot of times I want to say for the antidiarrheal medicines, they'll want to wait to be sure. They say, oh, the diarrhea is a good thing. We want to get all of the bugs or parasites or whatever out, because we don't want to slow that down until all of that has run its way out of your system, which is not what the patient wants to hear, but it sometimes is necessary. Antibiotics for sure. So that means, of course, whatever you're bringing up or whatever is shooting out the other end, they'll want to send to the lab, test for parasites, pathogens, and to see if they're treating your gastroenteritis the right way. Now, outcomes, this is pretty self-limiting. It's usually over in a couple of days, okay, if treated properly. Unless, if this has been going on for a while and it ends up being a very nasty parasite, you'll need to be admitted to the hospital for further workup and for antibiotics for a longer period of time. That's worst case scenario. Usually this is self-limiting, you're out, you're done with it in a couple of days. So that's the good part of it. And there's some examples here of, different kinds of, parasites, pathogens, etc. Some of them your worst nightmare. So, okay, again, this is just a repeat. Self-limiting bacterium or parasite is usually the culprit. A lot of fever, fatigue, dehydration. Blood work, they'll probably want to see what's going on. Complete blood count, chemistries. Testing your stool. Dehydration is a big consequence. Metabolic acidosis. Treatments. Rehydration is usually the first line. Let's get them fluids back into you. Antibiotics. Later on, probiotics. Any antibiotics they put into you is going to have a consequence of destroying the normal flora within your stomach. Unfortunately, but it happens. It's a consequence, but it's expected. Recovery, usually pretty quick. Yeah.
How common is this problem caused by parasites?
Well, it depends on what part of the world. Maybe you just done some traveling. Traveler's diarrhea may be a result of parasitic infection. And it also may depend on the cleanliness and preparation of the food wherever you just ate. And so that's why hygiene when preparing food is so important. So that could be a possibility, or I want to say, could be you. Maybe whatever you did with whatever fresh produce, meat, etc., maybe you didn't cook this long enough. Maybe you didn't wash this and, clean it out as well, or clean it up as well before preparing it. So it could be one of those three things. It could be you picked the parasite up from, I want to say, exposure to, animals. My goodness. If for some reason you got some of this on your hands and it found its way into your mouth, I want to say that's also a portal of infection. So, and this is why we harp on, hygiene so much as nurses. Wash your hands, wash your hands, wash your hands, wash your hands. If you can't do that, alcohol, use foam, use the gel. But I'll clue you in, sometimes alcohol, gel, and foam doesn't kill the parasites. That's why it's better to remove them mechanically, physically, with actually washing your hands with soap and warm water for a certain amount of time, and getting in all places to make sure you've removed, most all, if not all, those pathogens. So that's why we harp on it so much. It's a good question.
Rob, you mentioned probiotics and antibiotics, and I know what antibiotics are. What are probiotics?
Well, those are, all of you probably had yogurt. Like, lactobacillus is a common good bug that, favors digestion. It is a good bacterium. A bad bacterium in the stomach would be a bloom of Heliobacter pylori, which is now responsible, we found, for a lot of ulcers in the stomach. So that's a bad bacterium. And then, there are other, if you look at it, you can, I think over the counter, you can get lactobacillus. That's a good bacterium. But that is something that if you're on antibiotics in the hospital for a long time, I mean weeks, several days to weeks, they will usually include a probiotic to go with that. And that's the reason why they do. It's because some of these antibiotics wipe out the flora of your gut. They will. And so, yeah, for a while I was on probiotics initially when, irritable bowel was first diagnosed. And then I was told by the gastroenterologist, nah, you need to adjust your diet. That's where you need to go. I don't recommend probiotics. They don't do a whole lot. I thought, wow, we're doing this in the hospital. The GI doc says, do this, don't do this, do this. Conflicting information. I like what Deb Lucas talked about last week in regards to diet. Putting more variety from different sources into your diet. That will help favor and build up the right gut flora that you need. Okay. Does that help?
Sauerkraut's good, right?
Well, it is if you don't have any.
I'm still confused. You basically antibiotics the doctor gives me if I have an infection.
Right.
And then you're saying there's also some probiotics,
Right.
something I should take because of the
Yes.
antibiotics.
Yeah, and what happens with antibiotics is they destroy the infection, but they also destroy the normal gut flora. That's what you need to know. And that is why you may need to add something else to your diet that has the good bacteria, the good gut bacteria, like yogurt cultures, etc. And that's why you see all kinds of yogurt commercials. My God, there's a whole area of dairy in supermarkets just dedicated to yogurt. And once you get rid of, destroy most of the gut flora, you have to have some way to replenish that. And that is where probiotics come into use.
Okay, thank you.
You're welcome. Let's see here. All right, diverticulosis. Now, this is happening in the lower gut, large intestine, the colon. I was, I was still amazed that they still don't know why diverticulosis develops in the first place. They did mention that part of the outpouching may be due to increased intra-abdominal pressure, which, has to go somewhere within the gut. So guess what? It finds weak areas within the lower gut and it pouches out. So that makes sense, but, still, that's still not clear to me why this happens. That again, I mentioned here, the increased colon pressure is what is behind it, or at least partially behind it. Now, what happens is that food, stool collects in these pouches. It's not supposed to do that, but it does. And bacteria, they flourish in those areas. And the bacteria and this collection of stool, etc., causes inflammation. All right. And these pouches put you at risk for infection in that part of the gut. So this is what, if not taken care of, if your diverticulosis, which is, again, that is small pouches developing in the colon. That's what it is. If it's not taken care of properly, if it's not seen to, you could end up with a more serious form called diverticulitis. And that is where basically these pouches and all along the gut in that area start becoming inflamed. I want to say there's areas where they could start bleeding, swelling. I want to say more and more collections, of course, of these outpouchings, these diverticula. I remember when I had my colonoscopy, the doc was moving his camera from the behind up my gut, and I could care less. I had had sedation, so I was just looking at the TV. He says, oh, there we go. There's a few diverticula there. Nothing to worry about, Rob. And he's, following up here. He says, well, I don't see anything really serious, just a few diverticulum. I don't see any polyps, no cancer. I don't see any what looked like what's the term on my head? Lesions. Anything that looks like a serious lesion. So he says, you got off good. I could care less as long as I didn't hear the words cancer or diverticulitis or, yeah, by the way, you have a lot of polyps. Guess what? While I'm in here, I'm going to snip a few and take some. As long as I didn't hear that, I was okay. Yeah, I was relieved. So, yeah, a couple of years here on my 65th birthday. I'm going to have another one. But yeah, well, it happens. So what is behind this? In your digestion and while you're eating, you're not getting enough water in your diet, number one. You got to have water. You have to have water, especially as you get down into the lower intestine. Water is usually absorbed down there. However, it makes the stool less hard, easier to pass instead of being more likely to move slowly, really slow, and find its way into these small pouches. Plus, the fiber gives it bulk and allows it to pass easier. And so usually these diverticular pouches develop because of a lack of adequate water and a lack of fiber in one's diet. So why does this occur? Again, it goes back to, I think Deb Lucas touched upon the variety of foods that would add bulk and fibrous, whether that's like, oh, for heaven's sake, sorry about that. I just had a brain fart. Soluble and non-soluble or non-digestible and non-digestible fiber, which if you're really getting a variety, you'll get a good amount of both. However, the good news is diverticulosis is usually not associated with bowel cancer. The bad news is that it can lead to more serious conditions like diverticulitis. So with this, though, the usual symptomology, nausea and vomiting, cramping, tenderness in this part of the gut, constipation. Well, simply put, if you're not drinking enough water, stool becomes hard, difficult to pass. Okay. I want to say, usually correcting those matters lead to fewer incidents of this diverticulosis. May never completely get rid of it, but it could improve things drastically. Best treatments, depending on the severity now, might have very, I want to say your diverticulosis may be mild, or it might be more severe. So depending on the severity, they may actually put you on an antibiotic for a short period of time. Mild cases, usually antibiotics aren't needed. Usually, if it's a more moderate to severe or serious, they may include an antibiotic. What you might do too, if this is happening, is you might back off your diet in order to give your gut a rest. And that goes for any of these things when it's the gut and intestine related. Back off any way of what you're eating, maybe clear liquids, advance is tolerated. This is what we do in the hospital all the time, all the time. Somebody's put on gut rest for a couple of days to allow whatever's going on here to settle down, all right? And then introduce food, solid food, slowly but surely, okay? All right, it's a process. This is something we do in the hospital all the time. It's something you can do too if you're having a flare-up. Well, back off, go to other clear liquids, etc., for a day or half a day, etc., until this, give your gut time to rest and relax. So avoid nuts, seeds. Why do you want to avoid these items? Popcorn? Well, because basically these are things when they get down in that part of the gut can get lodged into these tiny sacs, the diverticulum, especially seeds. And I love foods with seeds in them, but I know that these things are troublesome anyway to my gut. But they say avoid nuts. I said, oh my gosh, avoid nuts too, popcorn? What the heck? But this is like when you have flare-ups, so it makes sense to me. Now, flare-ups can occur and diverticulosis can occur in general with somebody who's eating a high-fat diet, low vegetable, low fruit, okay, low seed, and legume kinds of diets. They're eating more, for lack of a better way of putting it, junk with less nutritional value. And this is why Deb Lucas's, her PowerPoint is very important as a go-between between gut anatomy and this, because what happens, anything that happens to the gut is actually going to affect, one way or another, it's going to affect proper digestion and absorption of nutrients, vitamins, fats, proteins, and water absorption. And that is why paying attention to your gut is really important. That's why you want to take care of a lot of these before they become serious. So does that make sense? I chose these for a good reason. They wound up on the list of very common digestive ailments without getting into other things that are more severe. But they showed up on consistently on lists that I perused on the internet. So, well, they can't be plagiarizing because these are coming from different sources. So questions, concerns, troubles, reminders. Diet plays a major part when it comes to some of these conditions. Sometimes it can bring on something bad. Sometimes it exacerbates an existing condition. Avoid, knowing to avoid and what to avoid to prevent flare-ups. That's key. Your gut microbiome is affected by your use of antibiotics. However, there are also other drugs that may have an effect. Sometimes long-term NSAID use can have an effect on the gut microbiome. And I want to say digestion and absorption of certain nutrients in the gut. Now, your own nutritional status, of course, is dependent on how well your digestive system depends on the healthiness or lack of healthiness of your digestive system. Okay, good functioning. Water also appears to be a very big factor. At least under certain bowel conditions. And generally speaking, if you're dehydrated on a regular basis, you're going to have trouble passing stool anyway without any of these other troubles that you may worry about. Well, gosh, I'm constantly dealing with constipation. How much water do you drink? Oh, maybe a couple glasses. Ooh, okay. That's when I advise a patient, look, you need to drink at least 8 glasses of water a day. Yeah, that's hard to stomach. But it serves a very important purpose. You could eliminate or moderate your constipation by doing that. So, that's, when talking to patients, a lot of this stuff, reminds me of patient teaching I once did at the bedside. And lastly, of course, you don't want to ignore signs and symptoms, okay? And believe they'll go away. Likely they won't. Because ignoring ignorance can lead to big trouble in some cases. And so that's why you just want to stay on top of that and notice your bowel changes. So you've got to know your body, basically. Know your body. Know what's going on, knowing what's normal for you and what's not. That's kind of how I want to end this.
Thank you very much, Rob. It was very informative.
Oh, I'm glad you thought so. Thank you. Appreciate that.
Thank you.
You bet. You bet. Anybody else? Questions, concerns, comments, troubles?
Can you say something about sauerkraut?
Oh, yeah. I love sauerkraut, cabbage. Although when it comes to, oh gosh, kimchi too. Where is it? Where did I mention that?
I know it neutralizes certain.
I think
poisons.
with IBS, for some people, now this is not universal, but with some people, any one of these beans, legumes, fruits might trigger an IBS episode. Now, cabbage might do the same, but it doesn't mean this is not an exhaustive list of what can trigger that. I mean, for me, what has usually triggered my IBS is stress. Stress. And I should have put this in here, but what's been known sometimes to treat IBS is to put a patient on, I want to say, a low dose antidepressant, an antidepressant that has as few side effects as possible. So again, that has been common practice for at least the last 20 years. It was one of the devices, one of the treatments my primary physician used to help me deal with IBS. And then occasionally he would put me on another antispasmodic called dicyclomine, also known as Bentyl. And that, well, before that, actually, I should preface that. He put me on belladonna before that, because that has a very, almost an instant effect on the gut to quell spasming in the gut due to irritable bowel. Trouble with that one is that one thing that it can lead to is constipation or paralytic ileus. So he took me off of that and put me on Bentyl, which has fewer side effects, but it is in the same drug class because it is an alkaloid of belladonna, but it has fewer side effects. Sorry, that's boring. Don't need to know that. It's just that sometimes antidepressant therapy has been used.
Question.
Yeah, go ahead.
What is it about depression, anxiety?
Now,
What chemical, I'm assuming that makes the body release a chemical that somehow.
it does.
It's not magic.
It can. Yes, because when you're depressed, anxious, it leads to worry. And worry can lead to stress as well. But we're talking about the sympathetic nervous system, stress, fight or flight. It ramps everything up. And everything from blood pressure, heart rate, breathing, to, I want to say, overactive acid production in the stomach, irritation in the bowels. I want to say it has just the opposite of the parasympathetic, when parasympathetic wants to bring things back into the status quo. Sympathetic does just the opposite and sends its signals either by the nervous system or by way of glands and hormones that have a direct effect on target organs, I want to say. Because when you think about it, if you're in a flight or flight episode, the target organ it's going to work on first is the gut. Slow things down because it wants to shunt blood into other areas, including the intestine. Shut it down some, slow it down. That has a direct effect on your digestion. When you think about it, parasympathetic, once fight or flight, you're out of danger, it helps return your system to hey, we're back at a nice, hey, everything is in a nice smooth sailing here. Now my gut can relax. I can go back to the status quo and everything's fine again. So that is how it does this.
Kind of mechanical.
There is, yes, there's an electrical and there's a chemical aspect to it. And then those organs that they affect will, I want to say digestion in particular. There will be, I want to say a chemical, mechanical, and nervous response happening.
It's gonna have a black microwave or a white.
Oops.
That's no good.
Oh, somebody doesn't have their mic off. But in any case, that's a very good question. I learned that over time why the doctors were using certain antidepressants to help with somebody who has frequent attacks of irritable bowel. So
If you're gonna get depressed, you should do it on an empty stomach.
Yeah.
I'm joking. If you're gonna get depressed, do it on an empty stomach.
yeah, because right. I mean, a lot of this can lead to indigestion. Okay, I'm going to stop share though anyway. Here we go. And I'm going to end this.